and welcome to Project First Line, the mini-series podcast on infection prevention. The Arizona chapter of the American Academy of Pediatrics is proud to partner with the American Academy of Pediatrics and the Center for Disease Control and Prevention's Project First Line to bring you this podcast series. I'm Dr. Sean Elliott, a pediatric infectious disease specialist at Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and medical director of infectious diseases and immunizations at the Arizona chapter of the American Academy of Pediatrics. I do not have any financial relationships or disclosures to share with you and no interest with any ineligible companies. This is session 1, all about syphilis, HIV, and the newborn infant, and we're going to talk about manifestations of these and basically how to prevent them or recognize them as they occur in our patients born to mothers who themselves are infected. So I think first and foremost, why are we even talking about this? And unfortunately, Arizona is really good at a couple things, one of which is congenital syphilis. In the past 5 years, we have been in the top 5, in fact recently top 2 states in the country for rates of congenital syphilis. This is unfortunate, obviously, because it means that we're missing a whole bunch of potentially preventable diseases. Every episode, every case of congenital syphilis represents a sentinel event where the mother was missed somehow with active disease or inadequately treated disease. So this is all potentially something which we can advocate for change in terms of protecting the safety of our pediatric patients. Similarly for HIV, although thankfully the protocols and recognition strategies for babies born to mothers with HIV have been perhaps a bit smoother and perhaps a bit more easy to follow, but there are still those rare episodes where we're surprised by a new positive, which may or may not be a true positive. So that's why we're talking about this. And I think to start off with, what does congenital syphilis look like in the newborn infant? And also, what does perinatally acquired HIV look like in the newborn infant? For syphilis, the majority of babies who are born with congenital syphilis are such because they're born to mothers with either untreated or inadequately treated early latent syphilis, rarely primary or secondary syphilis, just depending on their time of presentation. What does that mean for the baby? It means that baby's been exposed in utero to active syphilis and or sort of latent syphilis, but still there's exposure to Treponema pallidum, that lovely cause of syphilis, and therefore baby must be considered infected in utero. That does not mean disease, and a majority of the babies that we're seeing are thankfully not showing evidence of clinical syphilitic disease. What is that? Syphilitic disease in the baby, especially in the newborn, is potentially going to be evidence of periostitis or osteitis of the long bones. So if one were to look at skeletal surveys or x-rays of the especially the arms and the legs, one would see mottling and evidence of periosteal reaction at the epiphyses of those long bones. The most sensitive places, at least in my personal practice, to look for those changes is at the distal femur, proximal tibia, and also at the proximal humerus and the scapulo-clavicular junction, where one can actually see prominent mottling of the clavicle itself. So that is perhaps one of the most common changes that one sees with congenital syphilis in the newborn period. One also may see rash. Now, this is not the classic gume or gume, if that's how you pronounce that one sees in primary or actually secondary syphilis. And instead, in the baby, it looks like really, really exaggerated post-dates skin. So that sort of severe desquamatory rash or lesions which mostly appear on the palms and the soles. So large patches of desquamated skin with fairly erythematous dermis or epidermis underlying that. Hard to differentiate when there's a certain percentage of healthy full-term babies who have that same desquamation or just sort of dry infant skin rash. So if one wants to try and get a sense of the difference, just simply pull up pictures on Google, consult Dr. Google, I can't believe I'm saying that, as a good indicator of what severity we're looking for. And it is really quite striking. So that would be skin disease. Then also there can be occult hepatitis, or sometimes even pronounced hyperbilirubinemia, jaundice, in a baby who does not fit into any of the three classic categories of jaundice, i.e. physiologic, breastfeeding, and breast milk jaundice. So if one doesn't know to look for it, one may not discover the fact that the transaminases are significantly elevated and there's actually perhaps some synthetic dysfunction of the liver. So those are the classic ones. What everyone worries about, of course, is the occult neurosyphilis in the newborn infant, which can present in a very occult or indolent fashion, but ultimately presents you with a highly irritable baby with disorganized function, so unable to latch or unable to suck and swallow, perhaps ultimately developing seizures. So the point, I guess, to make is that typical congenital syphilis is silent. There's no active evidence of disease, but we certainly look for that in every baby born to a mother with or undertreated syphilis. Then for the patient born exposed to HIV, again, in the newborn period, this is typically going to be silent as well. But ultimately, those babies may go on to develop persistent or refractory thrush. Very typically, they'll develop significant cervical lymphadenopathy, followed by generalized lymphadenopathy. Sometimes the babies will present with what looks like parotitis in the first couple weeks of life. And then, if unrecognized and untreated, obviously, then they may go on to develop opportunistic infections. The very first opportunistic infection that a baby with perinatally acquired HIV may show signs of is pneumocystis jirovecii pneumonia. So that sort of non-specific pneumonitis, which then on chest radiograph appears with ground glass appearance of pulmonary parenchyma. And that patient may present simply with tachypnea followed by an oxygen requirement. And ultimately, if one does a blood gas, you may see an enlarged, arterioalveolar AA gradient. But again, the point is that this does not happen immediately. So what we are really faced with to recognize and treat these babies effectively is to do an even better job of screening the mothers. This we'll get into in just a little bit further in this podcast about what we currently do and what we potentially could do even more effectively. So that's how syphilis and HIV may present or not present in the newborn period. What do we do about it? So classic case, thankfully a mother who is screened by an RPR, and she's hopefully has been screened several times during her pregnancy. But if we have evidence of untreated syphilis or undertreated syphilis, I keep saying that. What does that mean, actually? Before we talk about the baby, what does undertreated syphilis mean? So a mother with early latent syphilis at some point in her pregnancy deserves at least 2 intramuscular doses of penicillin G spaced by 1 week. If those are administered prior to 30 days before delivery, then you might consider the mother to be effectively treated. She may still have a positive RPR. Hopefully it is a decrease in titer strength by at least 1 full dilution or perhaps 2. But just by proving or confirming that she received, and she can tell you that she received 2 intramuscular injections of penicillin, typically in the gluteus maximus, at least 30 days before baby's born, that would count as effective treatment. Perhaps more frequently, though, we get the mother who has had treated syphilis in the past, but still has a persistent positive RPR and no treatment during this pregnancy. That must be considered the potential for latent syphilis, because we don't know if she just has, an initial response from a year ago, several years ago, to her first episode of syphilis, and is just living with low titer RPR, or if that actually represents active or latent disease. Because we don't know, and because the risk to baby is extreme if we don't treat, we must consider that as untreated or undertreated syphilis as well. So the key is, if a mother does come to medical attention, is treated for syphilis, but is treated in the 30 days right prior to delivery, that is insufficient to prevent transmission to baby, and therefore we must consider baby exposed or infected with syphilis. Hence, undertreated mom, treat the baby. So now let's move to the baby. We have a baby that we suspect has congenital syphilis by maternal risk factors, by a positive RPR. The first thing we'll do, of course, is obtain an RPR on the baby. But ultimately, that's not going to give us a huge amount of information to prevent treatment. We're going to be treating regardless. What it tells us, though, is if baby themselves has already developed active syphilitic disease, not just infection, not just exposure, but active disease. So if baby's RPR titer is 4-fold higher than mom's RPR, that is felt to be clear evidence that baby has their own active disease. Anything less than that, and typically these babies have an RPR equal to or less than mom's RPR, they're still infected, right? We still have to treat, but at least it's reassuring that they did not have evidence of further active disease within them. So we do the RPR, and then we obtain long bone x-rays. We obtain a liver profile, whether that's a hepatic panel or in some cases a comprehensive metabolic panel. What we're really looking for are the transaminases and the bilirubin. So if you're able to order those individually and specifically in terms of a choosing wisely and minimizing cost perspective, that's ideal. And then the baby does need a lumbar puncture with spinal fluid sent for a VDRL. And that is to tell us whether baby might have early neurosyphilis. Presence of neurosyphilis or presence of a positive spinal fluid VDRL is going to extend our length of treatment with the penicillin. Typically, we treat for 10 days with intravenous daily penicillin. That would be extended to 14 days for positive spinal fluid VDRL, and also typically for positive findings on long bone x-rays, etc. And if baby is symptomatic, meaning irritable, disorganized, or having seizures, many practitioners will also extend that penicillin to 21 days for active disease with neurosyphilis. So that would be the evaluation. So long bone x-rays, liver profile, spinal fluid for a VDRL. Many also get a CBC differential just as a screening for invasive disease. And then we treat with penicillin G intravenously, 50,000 units per kilogram per dose given Q12 or every 12 hours in the first 7 days of life, followed by Q8 dosing, that same 50,000 units per kilogram per dose given Q8 or every 8 hours once baby is 8 days of life and older, and we give a total of 10 days unless they have evidence of disease, in which case we extend to 14. Pretty straightforward. And in fact, in centers that see a fair number of deliveries and thus a fair number of babies with congenital syphilis, this has almost become routine. It shouldn't be because we need to evaluate each case individually, but yet still, I think there's a fair amount of practice and experience with treating and evaluating babies with congenital syphilis. What about the HIV baby? So this too is well based on evidence-based protocol dating back from the 1990s, the protocol from the AIDS Clinical Trials Group 076. And in this, there are 3 things that need to happen. First, assuming mom has been effectively diagnosed or recognized to have HIV, mother needs to be on antiretroviral therapy. In the early days, all we had was zidovudine, AZT. So mom would be on that during her pregnancy. Nowadays, of course, we have highly active antiretroviral therapy as a 3 or 4 drug combination, the so-called HIV cocktail. And so presumably and hopefully mother has been or is already being treated with combination antiretroviral therapy and has achieved an undetectable viral load, which would mean with a quantitative reverse transcriptase PCR, RNA PCR for HIV, that we're not seeing any copies of RNA from the HIV. So that's step 1. Step 2, when mother presents to hospital in labor, she is put on continuous infusion zidovudine unless she has known resistance, in which case many times we just continue her antiretroviral regimen and consider actually delivery by cesarean section to minimize the perineal transmission risk from exposure to cervical secretions. But step 2 is mother on continuous infusion antiretroviral therapy. Step 3 then, here's where we come in, is for baby to be started on zidovudine, AZT, ideally within the first 6 hours of life, and anytime after that, of course, if we can't get it to happen, we need to start it as soon as we can, but the risk of transmission increases the further out from delivery we go without getting baby treated. So zidovudine for the baby, hopefully in the first 6 hours of life, 4 milligrams per kilogram per dose, twice a day, and baby will remain on that treatment for 6 weeks while we do additional testing. In the old days meaning the 90s and early 2000s, we would test baby at birth, at 2 weeks, at 6 weeks, at 4 months by HIV PCR, and again at 12 and 18 months with HIV antibodies. Turns out, in retrospect, that was potentially overkill because we became so successful at preventing transmission to baby. So the current protocol, unless it's a high-risk delivery, meaning mom has a new HIV diagnosis, not on antiretroviral therapy, and or there are other associated risk factors, and we just don't know mom's HIV status. But in the typical setting, a mom is well controlled with her HIV regimen. We test baby at 2 weeks and 4 weeks by an HIV PCR, and if those are negative, then baby can be considered presumptively HIV negative, and we stop the zidovudine at 6 weeks of life. Then we do one more HIV PCR at 4 months of life, and if that is negative, then baby is considered definitively HIV negative, and we're done. No need to do further antibody testing at 12 months or 18 months. This is a change from what you may be used to for those of you who have been in practice a bit longer than the last couple years. So it's actually relatively straightforward. And obviously, or maybe not obviously, but if you're in a community which has a pediatric infectious disease practitioner, they are certainly going to be very happy and willing to assist with this process and to give advice as to what happens next. In the unfortunate event that baby is born to a mother with uncontrolled or newly diagnosed HIV, and we don't know what her resistance patterns might be, etc., then sometimes, and again, this is with the guidance of pediatric infectious diseases, sometimes we'll start baby either on a full combination antiretroviral therapy regimen with 3 or 4 drugs, or at the very least use zidovudine and nevirapine, a non-nucleoside reverse transcriptase inhibitor. So it gets complicated in the setting where we miss finding the mom and have an untreated or unknown undertreated mother with HIV. So that kind of takes us then to how can we prevent that unknown or undertreated both syphilis and HIV. And the key really rests upon our adult colleagues or adult medicine colleagues and on obstetrics and gynecology colleagues. So screening during the prenatal period is critical. And ideally, and for those of you who practice in or around Maricopa County, there, your local obstetrics specialty group is doing it right. So they screen the RPR for pregnant moms at 3 times. The first is upon entrance into prenatal care at whatever trimester that may be, hopefully, presumably first trimester, but just in case they come a bit later, they as soon as they engage care with this newly found pregnant mom, an RPR is performed. And then again, at some point in the early 3rd trimester or late 2nd trimester, and then again at delivery. Some other parts of the state are just obtaining 2 RPRs, one at entrance to obstetrical care, and or just by definition sometime in the 2nd trimester, which is when they obtain other prenatal screening labs, and then again, hopefully, at time of delivery. Obviously, at time of delivery is too late to perform treatment for mother, and so all we're doing there is trying to capture the unknown mom who became infected in the last couple weeks or months for pregnancy, and or the mother who did not have a prior prenatal screening. Ideally, though, and this is, I think, something we can advocate for with our obstetrical colleagues, the more frequently we get the RPRs, the better. Certainly, 3 times during the pregnancy, as Maricopa County has been doing, is the most effective and has been quite successful, actually, in recognizing moms who are unknown syphilis or latent syphilis and getting them into treatment. So you may be asking, well, gee, if Maricopa is so successful, there's a lot of deliveries there. Why is Arizona still number 1 or 2 or 5 in the country for rates of congenital syphilis? It probably helps if I suggest or inform you that we're also in the top 10 states of the country for primary and secondary syphilis, and that a majority of those cases are occurring in counties outside of Maricopa and Pima counties. In fact, many of those are occurring in parts of our state that are marginalized, underserved, decreased access to care, and also occurring, unfortunately, on several of our native reservations. So nothing against the tribal governments whatsoever. It's just that challenges of transportation, challenges of access to care are even more extensive when one is living in a very rural and marginalized community. Also, and this is an unfortunate reality, a decent number of our mothers with syphilis are also experiencing homelessness and polypharmacy substance abuse. So this is a very difficult patient population to reach, in large part because they rarely access care except for emergency. So it's a very passive uptake of health care. And the only way to respond to that is to actively go and seek these mothers, potentially with a mobile health event, traveling health van or something like that, to do the screening and to be prepared to give penicillin, and similarly to do the screening for HIV, and then to get those mothers engaged into HIV care with the local HIV treatment center. Sounds easy, right? No, of course not. It's very difficult, and that, I think, is perhaps our biggest challenge right now. Certainly, in my interactions with our local county health department, we struggle with how to do outreach care to identify these mothers to be who may be infected with syphilis or HIV. And it's a resource issue. It's also a logistical issue, and certainly it's the ability to place a traveling van onto reservation lands, for example, or other parts of the county or parts of the state where jurisdiction may be a challenge. So, not proposing there's an easy solution to this, but I think if we can continue to advocate with certainly the Arizona chapter, the AAP, and with our obstetrical colleagues, and certainly with our county health departments, locally and then eventually, hopefully statewide, we can do a better job of screening for these mothers, get them detected, get them treated, get them into care, and then hopefully ultimately avoid the frequent encounters where babies are born exposed to or infected with congenital syphilis. So there you go. That sort of in a nutshell is where we stand currently in Arizona with syphilis and HIV and the newborn infant. In upcoming regular podcasts through the Arizona chapter of the AAP, I'll be partnering with several other state providers and the Arizona Department of Health Services to focus even more on this issue, to give us specific numbers of rates of congenital syphilis and HIV and other sexually transmitted infections, county by county and region by region, just to help us identify where are the biggest opportunities to intervene. So until then, though, thank you for listening to this podcast. And again, this is a part of the Project First Line partnership between the AAP and the CDC, focusing on infection prevention, which starts with disease recognition, treatment management, and then preventative steps such as we can take them. So thanks for your attention, and keep carrying on the good fight. Hello, and welcome to the Project First Line mini-series podcast on infection prevention. The Arizona chapter of the American Academy of Pediatrics is proud to partner with the American Academy of Pediatrics and the Center for Disease Control and Prevention's Project First Line to bring you this podcast series. I am Dr. Sean Elliott, a pediatric infectious disease specialist at Tucson Medical Center, Professor Emeritus of Pediatrics at the University of Arizona College of Medicine, and Medical Director of Infectious Diseases and Immunizations at the Arizona chapter of the American Academy of Pediatrics. I do not have any financial disclosures or relationships to share with you, and no interest in any ineligible companies. Today's session is session 2 on pediatric hospital-acquired infections, and we'll explore what this means for all practitioners, not just those who practice primarily in hospital, but those of us who also have an ambulatory component. The first thing we need to discuss, however, is what is a so-called hospital-acquired infection. And in fact, the new terminology is healthcare-associated infection. That means, and as we'll discuss, that risks to develop infections in all patients, whether hospitalized or not, do have a potential origination in the community. So things that we do in the primary care practice or subspecialty practices can affect children developing infectious diseases later on in hospitals and or even as an outpatient as well. So, official definition of a healthcare-associated infection is an infection which develops in the hospital. So again, there's that sort of much more historic definition, but develops in hospital at least 48 hours after admission. So suggesting that it's something which more likely than not was acquired after admission to the hospital. Now, 48 hours is sort of a very, well, it's a difficult time slot because there are some infectious diseases acquired in the community which have a longer incubation period. But in terms of legislation and federal government restrictions, etc., they had to start someplace. So 48 hours is the cutoff, unless there is some clear evidence that the child's infection in hospital was clearly community acquired. So potentially one could argue, hey, the child who came in with a urinary tract infection and then developed influenza A on day 3 of hospital stay in the setting of the entire family at home positive for influenza A, one can make a case that that was not a hospital-acquired nosocomial influenza A infection. So I will say, and this is based on almost a decade of experience as an infection prevention officer at a large teaching hospital, it is very difficult to defend one's hospital and one's healthcare setting against charges by federal government and specifically Medicare, Medicaid stewardship in terms of preventing or avoiding the designation of a hospital or a healthcare associated infection. We're not going to focus so much on that in this podcast, but far more so on what do we see as pediatric healthcare associated infections, and what is the risks, and I think most importantly, what can we do to prevent them? What can we all do as practitioners caring for patients either in the ambulatory or the inpatient world? So what are the typical pediatric healthcare associated infections? And these are a little bit different than what we see in the adult world. In children, the number one pediatric HAI, healthcare associated infection, is a bloodstream infection, typically in the setting of having a central catheter in place, but sometimes not necessarily so. Those are followed by surgical site infections, then lower respiratory tract infections, and finally by urinary tract infections. Unlike in adults, where the UTI is the number one hospital-acquired infection, and it kind of makes sense if you think about the classic person who develops a UTI in the hospital, they typically have a drainage device in place, a Foley catheter, for example, and there may be colonization of the plastic with an ascending infection. So luckily, though, in children, most often, if they have a catheter in place, a Foley catheter in place, it's for a much shorter period of time than some of the adults who are dealing with much more chronic comorbidities and chronic healthcare issues. So where does the risk for a healthcare-associated infection come from? And here's the important part, because in large part it likely starts prior to hospitalization. And I've talked about this in another podcast actually, but the issue of prior colonization with a microbe which may cause a healthcare associated infection or perceived as such, and or even prior colonization with a healthcare associated microorganism not initially causing disease but for perhaps a bounce back admission, or a child who has frequent hospitalizations may have sort of picked up sufficient organism in hospital or in the healthcare setting, in the clinic, for example, to change their microbiome. Specifically looking at one such organism, Klebsiella, which typically is not something we see as a cause of routine sinopulmonary disease or UTIs, but certainly can be acquired in the healthcare setting, and if so, likely has a fair amount of antibiotic resistance. And as it turns out, studies have shown that asymptomatic colonization of the gastrointestinal tract with an organism like Klebsiella carries an 18% risk of that organism causing an actual bloodstream infection or urinary tract infection or other stuff in a hospitalized child. Similarly, a child who is colonized in the upper respiratory tract, and this could be from a prior intubation on a ventilator, prior respiratory treatments such as nebulized treatments or something similar, that child, after colonization with a non-native floral organism, has anywhere from a 16 to a 57% risk of that organism causing disease. Why the wide range? It really depends on how severely ill the child was initially when they became colonized. So those children who had mild disease and perhaps were just receiving some sort of Nebulized treatments without invasive ventilation, they're the ones with a 16% risk of eventually developing non-native healthcare-associated respiratory infection, versus those children who, as the term in the paper goes, are moribund. So severely ill on a long-term ventilator with an endotracheal tube and perhaps sedation paralyzation, all the risk factors you can imagine. Those are the children who ultimately have 57% risk. Important caveat, those are also the children who very likely are going to have additional special needs and chronic illnesses, which will also further increase their risk of subsequent hospitalizations and also having altered microbiome and healthcare associated infections. So the first and major risk for developing an HAI is that prior colonization, followed then by a need for an indwelling venous or arterial catheter. Interestingly, and perhaps this is just that sort of weird perception, we all think of arterial catheters, especially like a radial arterial catheter, for monitoring purposes, as being super high risk. I mean, that's arterial blood, for Pete's sake. As it turns out, though, because the pressure is higher, the flow is higher in arterial catheters, it's actually the venous catheters, such as your tunneled catheters, your PICC lines, your porticas, etc., that are the ones with the higher risk for biofilm formation and then colonization and infection with a non-native microbe, causing then a hospital or healthcare associated infection. So that, of course, is not something that most of us in the ambulatory world can have much impact on, other than ensuring that child with an indwelling catheter receives sterile practice care if they come to see us in the office. The next category, however, is something that we do have some impact on, and that is the category of antibiotic exposure, especially exposure to broad spectrum and or expanded spectrum cephalosporins. So this is important because we do have choices to make if we're treating a routine ambulatory or outpatient infection, such as acute otitis media, group A strep, a simple UTI. All these can be managed as outpatients. And we can choose to make the most focused antibiotic choice possible based on either known culture sensitivities and or local epidemiology. To avoid then the immediate go to broad spectrum cephalosporin, oral cephalosporin, is going to help that child down the road should they subsequently be hospitalized. Why is this even a big deal? And yeah, it's kind of stating the obvious, but antibiotics in general and the broader spectrum, the worse the risk, are going to alter the native microbiome, that the patient's own normal flora, which makes sense because these are organisms which carry a lot of good and sort of symbiotic and probiotic relationships, but they're also very susceptible to routine and broad-spectrum antibiotics, such as we use in the outpatient world. So if we are then treating with antibiotic, almost expected that there's going to be some impact, some negative impact on that normal flora. And you could say, okay, well, so what? Where's the harm in that? And the challenge is that as we reduce that indigenous flora, we're actually reducing protection against invasive flora. Again, sounds like a no-brainer, but what exactly is happening? The first part is that, and I think we could all come up with this easily, the normal or indigenous flora competes for nutrients with invasive species. And in general, they are hardier or more, they have better survival factors than an invasive organism, which for all of its nastiness and cause of healthcare associated infections, many times are sort of wimps when it comes to competing for nutrients. So the first and most important benefit of having that native flora is called bacterial interference, and that's the nutrient competition we talked about. The next, and this is interesting because this may not occur to everybody, is that native indigenous flora blocks adhesion by other bacteria. And it may simply be that normal flora itself is already adherent to, for example, the epithelial cells lining our gut. So sort of enteric and even endothelial cells lining small blood vessels are already, if they're already sort of covered with normal stuff, there aren't that many access points for a invasive organism to come. And even more so, there are specific binding interactions of normal flora to binding sites such as pili, P-I-L-I, and that's a big entry point for E. coli, especially some of the normal E. coli which colonizes the perineum. But should that E. coli get introduced after knocking out the good stuff into transitional epithelium in the bladder, it finds all sorts of happy, unexposed, unbound pili binding sites to which it binds and then causes the urinary tract infection. So the normal flora is not only laying on or covering the target cells, it's actually in many cases specifically binding to exactly those sites that would otherwise be targeted by a non-native or an invasive flora. So anything we can do to protect the good stuff, to protect the microbiome, is of course very beneficial, including even on those patients who will be on an antibiotic, to consider the use of probiotics, whether that's accomplished via live yield or live culture yogurt or even over-the-counter probiotic products. All those are going to help reduce the access points for the non-native invasive flora. Okay, so when we violate that, and again, sometimes we have no choice, this is just the way it goes, then that, of course, increases the risk for colonization and potentially invasion by pathogenic flora, which then contributes to the healthcare-associated infection. Next risk, again, we're still talking about risks of developing HAIs should that child be hospitalized. The next risk is inhalation equipment contamination. This is important. So I think many of us are familiar with the one-use or single-use masks and nebulized catheter tubes and cups for the nebulized solution, but sometimes those, for reasons that are mystical to me, get reused, and it's just not possible to clean them or sterilize them if they're not intended to have that done. So inhalation contamination is a definite possibility. Typically not the outlet ports of the medical gases in the office. Those are generally not the risk. It's truly equipment which comes into human contact and then for whatever reason may transfer between patients. And then finally, and this is hopefully much lower risk, but contaminated IV solutions and catheters themselves. Now, we all know and expect that intravenous solutions like the bags of normal saline or lactated ringers or whatever, and those lovely peripheral IVs which come in packaging, that all those are sterile when open. That is what we would expect. But sometimes that is not true. There have certainly been clusters and sort of epidemiologic nightmares when a manufacturer of a certain product has a contamination event at the site of creation. That can occur even after creation of the instrument itself and after the sterilization step occurs, and then prior to packaging. So those can happen. Also, and this is a bigger issue for those hospitalized patients, IV solutions, especially if they're prepared in the hospital, there's always the theoretic possibility of contamination. Now, multiple steps are taken to avoid that. For example, total parenteral nutrition, a perfect example of a high-risk IV solution, which is prepared in hospital because that's typically made to be patient-specific. However, the preparation is done using sterile practices in a sterile hood with appropriate airflow, masks, gloves, the whole 9 yards. So rare, but it is a theoretic possibility. So that's kind of the risks for the healthcare-associated infections. Let's really sort of now focus for the rest of the podcast on prevention. What are the things which we do and can do to lower the risk of healthcare-associated infections across the board for pediatrics? So the first part of that will be the types of isolation which we conduct typically in a healthcare setting. Most often, of course, this is in the hospital. So if you are a provider who rounds on children, babies, adolescents in the hospital, these, of course, all pertain to you. But even so, in some patients in the clinic, we will encounter these as well. And so it's good to know what it means and why they're indicated. So the first type of isolation are what are called the standard, otherwise known as universal precautions. And these come from the understanding, the expectation that all body fluids can be considered to be potentially contagious. Yeah, I know that's kind of a great big duh moment, but it's important when you think about it. So routine interaction in the clinic space or in the emergency department or in a hospitalized patient, of course, we talk about hand hygiene. We'll talk about that in just a little bit, but we gel into the room and there's no known infectious disease for the patient at that time. So we don't need to be wearing our masks or our gowns or our gloves or anything like that, except of course during the pandemic when we are still wearing our masks for the time being. But if we go into that room and there is a potential exposure to feces, for example, or urine or saliva or vomitus or something like that, that then would be considered a body fluid which is potentially contaminated or potentially infectious, and that is when we put on the gloves and perhaps the gown, depending on how significant the exposure might be. That's the concept behind universal precautions. Perhaps it's most expedient in the neonatal intensive care unit, where in general the babies are not highly contagious, right? They don't cough very effectively. They rarely have nasal secretions, but they do fill diapers. And so when the diaper change is occurring, that diaper change then is performed with sort of the equivalent of contact precautions. So wearing the gloves at the minimum, and if it's a diarrheal diaper, gown and gloves as well. That's standard or universal precautions. Contact precautions, just think of this as a physical barrier between you, yourself, and something which is potentially infectious. So this typically is used in the setting of contagious skin infections. MRSA would be, I think, a very important example. So too, bacterial enteritises, so like Salmonella, Shigella, Campylobacter, those would all be important to have a barrier prevention, so gown and gloves, when interacting with those patients, but not clearly a respiratory component of transmission. The respiratory isolation is going to be the majority of what we encounter during respiratory viral season, so the mask, and in some cases RSV, which has a contact risk as well. Those large respiratory droplets which settle down on horizontal surfaces, you may be wearing both. But classic respiratory isolation is going to be the regular mask, surgical loop mask if you will, and if there's going to be any sort of aerosol generating procedure such as performing bronchoscopy, intubating, suctioning, then mucosal protection with eyeglasses and the gowns and the gloves. Airborne isolation is sort of a very specific subset of respiratory isolation, and this has to do with especially viruses and also some highly resistant organisms or potentially resistant organisms like Mycobacterium tuberculosis. These are all infectious agents which can persist airborne, hence the name, for longer than usual, a couple minutes to an hour or so. So small virus or small bacterial particles which can remain airborne for quite some time. These are the patients who are then isolated in a room which has airflow instilled in it, so negative or positive airflow, depending on the pathogen, and in whom we should be wearing N95 masks because these are much smaller particles that can get through the surgical loop masks. And then one last category, and this is really specific to patients with Clostridioides difficile, or C. diff, and that will be the so-called enteric precautions. Kind of a misnomer because it's not for all enteric infections, so we don't need to do enteric precautions for salmonellosis or shigellosis or something like that, but absolutely those patients who have or may have C. diff. This is really, we're still wearing gowns and gloves and everything else, but rather than using the alcohol-based hand gel as our hand hygiene agent, we need to use soap and water. Why? Because the major pathogenesis of C. diff is not the organism, it's the actual spores and the toxins itself. And those are not typically responsive to alcohol-based hand gels, hence the physical disruption of using soap and water. So that's the types of isolations and sort of the general categories of infectious agents for which we need to wear them. That is sort of prevention step number one, and it should be easy to perform. However, I think many of you are saying, but right now, like every child in the hospital or every child coming in the clinic potentially needs isolation because they all have like the fevers and the runny nose and stuff like that, and I'm just tired of doing it. Totally understood. Sign blindness and isolation fatigue are two terms used absolutely when one is just so tired of doing isolation for what seems to be every single child all the time. And yet it's no less necessary for our own protection as well as the patients, and certainly for other patients whom we may see and inadvertently transfer organisms from patient to patient. So that's prevention step number one. Prevention step number two, antibiotic stewardship. And again, I've already referenced this when we were talking about the risks of HAIs. Anything we can do to protect the microbiome and prevent invasive species is going to be beneficial. So choosing the narrowest spectrum antibiotic necessary, even choosing an antibiotic only if necessary, and we all know this, of course, but for the record, I need to say it. And then if there's a potential to narrow the antibiotic coverage, whether in hospital or in a clinic setting, for example, we start broad as an empiric management and then narrow once we get culture results and or exclude the scary stuff. All those steps, even if they seem without immediate effect, actually truly have very major effect down the road in terms of what that patient may have as the microbiome, whether it's native species, indigenous flora, or something novel and potentially far more pathologic and invasive. The next category of prevention steps we can take then are to reduce the exposure. Of course, that makes sense. Prevention is the best thing we can offer, but how do we do that, both in the hospital and in the ambulatory setting? And the first step is to make it easier to avoid mistakes, right? I mean, we're all human, and the busier we get and the more fatigued we get, the easier it is to have a lapse in otherwise routine, normal infection prevention behavior, like gowning and gloving and monitoring the IV fluids and cleaning the hub for the central line, etc. So the number one way to reduce exposure is to ensure proper staffing of those hospitalized patients and even in the clinic setting. So protecting nursing ratios is critical, ensuring that the staff we have are sufficiently, hopefully, well rested as may be and not overburdened with shift needs and patient care. Next is to ensure sufficient space around the patient. This totally makes sense, of course. If anyone has participated in a rapid response or a code in a tiny patient room, there's a lot of people tripping over each other and, of course, violating infectious disease practices right and left because, A, it's a very sick kid, and B, there's not enough space to do things properly. So as much as is possible to have sufficiently large, clinic examination rooms and hospitalized rooms and to avoid cohorting just to provide enough space around the patient. 3 feet is the minimum in all directions, 6 feet is ideal, and then only to enter or sort of violate the bubble around the hospitalized patient when one is fully observing of the type of isolation necessary and is prepared for that. Along the same lines, traffic flow. So avoiding bumping into each other, again, no brainer, but it's amazing how many times we're just like moving low and fast trying to take care of a patient, and then whoops, I just ran into the respiratory therapist, or they just stepped on the shoes of the bedside nurse. So all those are going to potentially transfer organisms between us as healthcare workers and then increase the risk of transferring it to the patient. And similarly, just being aware that we can observe the protective bubble around the patient by monitoring our traffic patterns as well. And then cohorting. Now this is, it's kind of a difficult buzzword because in the older days, and still many hospitals observe this, where they have, multi-occupancy hospital rooms, there has been, and I did it as a resident too, the need to cohort patients with the same respiratory illness typically. So in my experience, that was cohorting patients with RSV and then patients with influenza. The challenge is that we're not just cohorting that one known virus, there may be other viruses, there may be other bacteria, and we're cohorting patients with different native microbiomes and potentially non-native microbiomes. So cohorting is really, as we're getting into having single-use rooms, is really the best way to go. And I think most hospitals are observing this as much as is possible. I guess, though, when I'm talking about cohorting, I'm really talking more about traffic flow and throughput in the ambulatory setting. And this came to light very much with the pandemic with SARS coronavirus 2. And that was have the first half of the clinic day be for the healthy, the non-febrile, the non-sick patients, and then have the second half be sick visits. So the kids with fever, the kids with respiratory illnesses, whatever, so that you're not potentially mixing healthy and sick in the same waiting room. And after the afternoon sick clinic, or urgent clinic, if you will, there's enough time for airflow or air exchanges to occur in the clinic setting, for cleaning to occur, and then to prepare for the next day of healthy. So if one has not already planned to do this, but cohorting the sick clinics for the end of the day is, of course, the most ideal way to go about this. And then finally, hand hygiene. Boy, easy to say. I think we all understand and I hope accept the importance of effective, proper hand hygiene. And in fact, some estimates are that 95% of disease prevention in the community, in the healthcare setting, in the hospital, comes from effective hand hygiene. 95%. And yet it's probably the one thing that we all as healthcare providers do least well. And here again, it's just so easy. Like, I'm just going in the room for a second to tell the patient something. Well, in that so-called second, which is far more like 30 seconds or a minute or so, estimates are that we physically touch high touch areas in that patient's room at least 3 or 4 times. without meaning to. And it's you can see how it happens. You enter the room, perhaps the patient or the parent asks a question, you go further into the room, and now I'm getting comfortable to answer more questions. It's the doorknob moment, and I'm putting my hand on the bedside table or on the end of the bed or just on the IV pole or something. I mean, it happens naturally in the course of conversation. So it's very easy, and this is of course not deliberate. I think all of us, when we're thinking of it and reminding ourselves to do it, appropriately gel in and gel out of the rooms. But sometimes there are other barriers. For example, having sufficient alcohol gel stations in proximity to the room. It's a lot easier to gel in if it's right there by the door and in you go. However, and this will surprise some of you, fire marshals get really bent out of shape if you have too many alcohol-based hand hygiene stations, because that increases the risk of fire. Believe it or not. Yeah, I know, it sounds a bit strange for those of you who are listening and shaking your heads, but that's exactly the kind of issues which we come across in the healthcare setting in terms of trying to balance need to protect safety of the patient versus risk to the environment. So sufficient stations and placement of the stations are known to be barriers to effective hand hygiene, as well as technique, so rub till dry. With the older versions of the the alcohol gel dispensers, you could get just a tiny little squirt, think that was sufficient, and rubbing till dry took like about maybe 2 or 3 seconds, right? Because there wasn't enough to cover the entire hand. Currently, the auto-deliver devices deliver what everybody I've heard says, oh my gosh, that's way too much. It fills my entire palm, and it's like this frothy jelly stuff I have to rub forever. Well, that's actually on purpose, folks. The drying time of the alcohol needs to be at least 15 seconds for it to do its job in eradicating bacterial and other microbes on our hands and our fingernails and the crevices between the fingers. So just as you recall from scrubbing into surgery, you got to rub that stuff all over the place, and you keep rubbing until it truly is dry. And it's a great idea to walk into the patient's room while doing that, so they can observe, oh, my healthcare provider cares about me because they're clearly doing hand hygiene coming into the room. That's an important thing for patient comfort and satisfaction as well. So it may be necessary to do occasional refreshers for the clinic staff and the nursing unit staff, etc., on how to gel in and gel out. And then occasionally, when one gets that sort of lovely little gummy buildup from lots of hand gel, to realize that you have to do soap and water washing event for the hands. So all this, of course, makes sense, and I'm sure we've all been through it 3 quadrillion times, and yet we still sometimes have oopses. So it's necessary to have those refreshers. Final part for the hand hygiene is to make sure that there's the ability of the hand cleaning agent to do its job, which means if there's gross contamination of whatever it might be, maybe you had to change a tire on the way in, or heavens forbid, there's some still stuck on body fluid from the last patient. I know, not likely, but it happens. To make sure that that's all cleaned off before doing the alcohol-based hand hygiene event. But also paying attention to the nails. So hospitals universally have policies and protocol preventing the use of the acrylic stick-on nails, or sort of the fake nails, because those products, those non-human tissue products, have been shown to retain significant microorganisms, especially including Pseudomonas and fungus. Yeah, they can actually demonstrate that by scanning electron microscopy, even after what the practitioner felt to be a healthy, appropriate hand hygiene event. Like they rubbed till dry, they used the soap and water, and yet those acrylic nails and or very extensive add-ons all retain pathogens, therefore potentially transmit pathogens to the patient. So in the hospital setting, fake nails are a great big no-no. I would suggest we consider that in the clinic space as well. And yes, that's going to cause a bit of a riot. But if your clinic has children who have chronic healthcare conditions and special needs who have the potential to be hospitalized, that infection prevention step starts in the clinic, and to avoid being exposed to Pseudomonas and fungus and all sorts of other nasty enterics from fake nails is, I think, a very good service we can conduct for our families. So there you go. In a nutshell, that's a whole awful lot on infection prevention in the healthcare setting and what healthcare associated infections actually are and or look like for pediatrics. Thank you once again for listening to this podcast. Again, this is session 2 on healthcare associated infections as part of Project First Line. And again, big thanks to the National AAP and to the CDC for supporting this. Thanks for tuning in, folks. Welcome to Project First Line, the mini-series podcast on infection prevention. The Arizona AAP is proud to partner with the American Academy of Pediatrics and the Center for Disease Control and Prevention's Project First Line to bring you this podcast series. I'm Dr. Sean Elliott, a pediatric infectious disease specialist at Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and medical director of infectious diseases and immunizations at the Arizona chapter of the American Academy of Pediatrics. I do not have any financial relationships or interests to disclose with any ineligible companies. Today's topic is session 3. This is a discussion with a director of infection prevention, issues associated with maternal fetal COVID-19, influenza, and other respiratory viruses. And with me today is a special guest. Thank you so much for joining us, Ms. Suzette Chavez, who is Director of Infection Prevention at Tucson Medical Center. Thanks for joining us.
Well, thank you for having me over.
It's great to have you. So just because not everybody knows who or what a Director of Infection Prevention is or does, can you just briefly share sort of your background and why you're doing this job and why you're good at it?
Why I'm here.
Yes.
So Director of Infection Prevention, that's a mouthful, but basically what we do is we make sure that we guarantee or try to guarantee to the best of our ability that patients are safe here when it comes to infectious disease and control in a hospital. I think our role was kind of in the highlight in the last couple of years because of COVID. A lot of people didn't know we existed. Now they know. And it touches a lot of ranges within the hospital. So we look and work with a lot of educators down to nursing, environmental services, facilities, all of the things that keep our doors open to make sure that we are safe. And then we deal with very complicated disease processes with the infectious disease department to make sure that visitors and patients are safe when they come to our hospital.
So it sounds like a very exciting, very dynamic position to hold. Daily challenges, nightly challenges?
All of the above.
All of the above, right, exactly. And you think you're going to have a nice calm day and all of a sudden, hey, guess what, we discovered da-da-da-da-da, right?
Correct.
That sort of thing.
Correct.
Okay. So coming into this position, did you have additional specialized training, experience? What brought you to this hospital?
My background's in microbiology. I actually started off working at the VA here in Tucson as a microbiologist. I tell people I used to grow bugs for a living, and my job is to prevent them from growing. Then went into infection control over at Tucson Heart Hospital, where we were a specialized heart cardiac center. Then went on to an acute care center. Been doing 15 years now of infection prevention. There is a certification process. At the time when I started my career, you had to have had 2 years in the field before you can get certified. Now it's a little more lenient. You could take the test before, but it's a little hard and challenging. There are 7 categories that they look at, anywhere from the disease process of CODI, CLABSI, ventilator-associated infections, all the way down to environment of care joint commission requirements. So now I'm here. Every 5 years we have to get recertified and keep our certification to be in a director level here at TMC.
So there's a lot that goes into this role for sure.
Absolutely.
And I imagine the most successful are those who already know the microbes on the first part, and then you're in the back end trying to prevent them. So super exciting. Good luck. So we're going to bring it sort of to the topic of discussion today, and this actually, viewing audience, has come out of national discussions, and we're not going to pretend to have any easy answers for this one. But to set the stage just a little bit, we've all come through the last couple years of pandemic with our dear friend SARS coronavirus 2 and all of the infection prevention challenges that entails, not least of which is to keep our patients safe once they're hospitalized, to keep our personnel and staff people safe as well. But a recent, and maybe not recent, but an issue which has recently come to attention, how about that, is that when we have mothers who have just delivered babies and the mothers themselves are sick with SARS coronavirus 2, having COVID-19, and actually recently other respiratory viruses, that presents some unique challenges if their babies are either happy, healthy, able to room in with mom, or sick enough to require further hospitalization in a neonatal ICU, nursery, etc. In the early days, so now go back to spring of 2020, we're just realizing what the heck is going on. What did we do when a mom was delivering a baby or had just delivered a baby and she herself was sick with proven COVID-19? What did we do with baby or with mom?
That was a really challenging question that we had to work with ID Doc very, very closely, because the CDC, who is supposed to guide us as infection preventionists, didn't really have a lot of the answers. So we had to kind of find this out on our own. And a lot of the times what we did is we went by symptomology. So we know that COVID initially at the beginning wasn't really hurting babies and young populations like they were with the adults. When we look at RSV, that's kind of of flipped. So with RSV in adults, it's a cold. It's a cold that we normally don't isolate for. But for babies, it could be very challenging. They need oxygen. They need to be taken care of 24/7. So it brings up a challenge that we always have to look at. And so we look at each individual cases and see if we can do the best. We know that there's an important factor to that mom-baby bond. And also even patient visitors. We saw this in COVID. We were lucky enough where all of our floors are on the first floor, so we were able to offer some of the visitors some window visits. A lot of hospitals didn't have that, but we knew there's an important factor in looking at your loved one, having the loved one know that you're there. Same thing with mom baby. There's that bonding that we don't want to interfere, but we also want to make sure that we're safe. And as a mother, if I'm told that something that I may be doing or I have in my body might be hurting my baby, I think that's very powerful. And as a mother, I think you can work out a lot of those things. One of the challenges that we talked about before was symptomology. It's always important. We have carriers that don't show any symptoms. With a lot of these infections, we can provide some personal protective equipment, and we're able to do some in between where they can have both bonding experience and not be a challenge. So we do those. We look at those on an individual basis and see what we can do so that we can meet both of the needs.
Sure. So you sort of hit the nail exactly right on the head where I thought you would. And thank you for that. And the big challenge, it would be easy peasy, best thing in the world if we could just isolate everybody, no visitors, close the door, and that's it, right? But we have critical bonding time, mother, baby, skin contact, et cetera, and so forth. And also support for a newly delivered mother and the family, et cetera. So it's not so very easy. So if I recall, we like you said, based on the symptoms of the mom, you would actually potentially isolate baby from mom, and or mom had to wear a gown and gloves and a mask and gosh knows what else, and put a HEPA filter in the room, but ultimately baby would go home with mom on day of life 1, 2, whatever it was, and they were going to be in the house, right? So even then, if I recall, we were suggesting that mother at home not nurse, not have close time, not have bonding time, and that some other care provider would take care of baby until mom was no longer contagious, 5, 10, 14 days, right?
Right.
So let's fast forward to today, where the CDC, if I recall, says, okay, 5 days after onset of symptoms, so long as fever-free without antipyretics, and mom wears a mask, or anybody else wears a mask, that they can come out of isolation or quarantine. Is that how we pursue things here in the hospital?
We do.
Okay.
We definitely do. And, we have challenges, just physical challenges in some of our NICU areas because they're Bay areas. So we would kind of take some of those babies and they would be in a big area with other babies. If we had situations like this, there are a couple of rooms where we could take that baby, put them in an actual private room so that mom and baby can have that bonding experience. So we will look at everything that we can do to honor the bonding and also make sure that our babies are protected, that our staff is protected, because that is the other thing, is that we want to make sure that when we do make these exceptions, that the staff understand the reasons why and that we're not just making it up as we go. Because a lot of times we do have to, think outside the box to make sure that we give everybody the opportunity they deserve.
Perfect. So now you've introduced that other very important element, which is what about the baby who has to be hospitalized in the NICU, right? This is not just a single mom-baby dyad in a private room, which we have, yay, thank heavens. This is now a baby going into a multi-bed, 42, 41 bed
42.
NICU, which most of the beds in bays or pods, right? So it's not just a single baby, and there's no private room other than some curtains, which, I'm sure we could debate forever the merit of curtains in preventing respiratory droplet transmission. So it's not perfect. Is that fair enough? So then we have not only to consider the risk to baby, but also baby and the other cohorts in that NICU.
Correct.
So,
and family members, because there might be a baby next to the baby we're trying to protect that is totally fine to have those visitors. Right. So we also have to look at placement and make sure that, we put those babies that are higher risk away from babies that may not. They may have visitors come in and out, because visitors can also bring in bacteria that can infect other babies and our staff. We want to make sure our staff stays healthy, because they obviously don't have a 1-to-1 ratio with everybody. So they're sharing between babies the care. So we want to make sure that placement is also important.
Okay. So placement, big issue. I assume length of days or amount of time that mom has been symptomatic. So obstetrics calls says, hey, we are delivering right now a baby. Mom is COVID positive. She's been been sick with symptoms the last 3 days, baby's premature, has to come to the NICU. What do we do with mom? Can she come visit? And how do we address that question?
We actually had that multiple times during COVID, and we always resorted to educating the mother as to, and most of them are very reasonable. If you say, in 2 days you can, let's try to honor that 5-day as best as possible with no signs and symptoms. But also we also incorporated the husbands or the other family members so that they were assured that their baby wasn't alone. So they had someone there that was negative for COVID that could be that, obviously not the same as a mother, but you still had that bond, and then they could come back and tell the mother how everything was. So again, specialized plans where we can look at those cases and make those arrangements accordingly.
Okay, so ideally not to visit until we're comfortable mom is no longer contagious by current criteria, et cetera. Okay.
Correct.
So that's for SARS coronavirus 2, which, as you've already said, is not a zero risk, but not a high risk to infants in a NICU, right? What about influenza? What about respiratory syncytial virus, which are a little bit higher risk to especially premature infants with respiratory disease? How do we approach that same exact scenario?
Again, it's symptomology. Because as I mentioned earlier, in adults, we can be carriers and have RSV or flu and not even know it. But once we start developing those signs and symptoms, obviously our babies become very susceptible to that. So again, we can mask a little bit different because with both of those are droplets, so we don't require that N95. We can mask the mother and then she can have those visits. Obviously, if she is developing droplets and coughing everywhere, we would discourage the mother from that. But most of the time I find, like I said, if you just describe the reasons why, and it's not us just trying to keep the babies away, they're very understanding to making those exceptions.
Okay. So that's great. What I'm hearing from you is sort of establishing a culture of adherence to infection prevention techniques involving, in this case, the mother, but the family, perhaps, as active participants. And that's not something which I've heard discussed a whole awful lot. It makes sense, right? It's like, hey, don't you want the best for all the other babies too, not just your own little one? Right, that makes sense. Obviously, those hospitals and neonatal ICUs that have a bunch of private rooms, things change a little bit. You can put them in, close the door. And we have a couple, right? Private rooms, not just bays. But if we're out of those or somebody else is occupying those, then we take the approach of empowering the family to help us do the right thing.
Correct.
Makes sense.
Correct.
Okay, all right. Is there any situation, and this is a hard question to answer, and I'm sorry, but is there any situation you could think of where it would be just a hard stop, like mom may not visit until ... I
think, again, I go back to symptomology. If you have a mother who has a high fever, has a lot of symptoms going on, and is clearly not past that incubation period, I think that's a hard no. And very few times do we have to, I will go in there, I'll talk to them, I will talk to ID doc, and once a couple of people go and talk to the parents, they seem to be okay.
Sure.
We can also use distance, can we put the baby somewhere where she can physically see the baby but not get within that 6 foot that everybody uses, just to see them, because maybe that's just reassuring that the baby's okay and they got to see the baby but not actually close enough for them to cause any kind of harm.
Makes sense. And obviously the ideal is always get mom and baby immediately together because we know about the skin to skin, the bonding, but this is a hopefully infrequent experience, right? Well, we have to be that.
Not very often.
Not very often, exactly. And I think if I also have experienced this extends to some other isolation issues, such as mother has an infection with a multi-drug resistant organism. For example, mastitis with MRSA. So there it's a contact precaution, and we can take barrier precautions as needs be.
Right, and we can, if it's contained to a certain area, we have this across the hospital, not just in mom-baby. If we can contain the wound or the source in some way, do hand hygiene, put a brand new gown, there's a lot of things that we can do to try to, to minimize any kind of exposure. To both the mom and the baby, but we will look at those case by case. And again, I'm happy that this is not a very often type of situation, but we're open to that. It's very hard to just say, as you know, with bacteria, they don't read the book, they don't follow the rules. So we have to be open to that and look at each case by case.
Right. And I think, again, that's why this is an important national conversation that's being held right now. It's not easy, and it sounds easy to sit here in this room and discuss it, right? But we're not actually right now face to face with an angry parent saying, I need to see my baby, and I completely respect that as well. One interesting, I don't know if it's a solution, but perhaps a workaround that our obstetrical colleagues have offered is if it's safe and they can do so, to delay delivering baby until mom is a little further on in her illness, whatever that happens to be. So, you're here to be induced. Maybe let's not start the Pitocin quite yet. Let's give you another day or two to cook and get better. And then, as long as it's safe for baby, that seems like another workaround.
Right.
Well, thank you very much. This has
welcome.
been very helpful. I hope this has been helpful to our viewing or listening audience. And if anybody who is listening to this podcast has additional experiences to share or additional solutions, we would love to hear them. Please share them with us, the Arizona chapter of the American Academy of Pediatrics. And thank you all for listening. This has been a Project First Line mini-series podcast on infection prevention. Sean Elliott and Suzette Chavez saying thank you and have a great day.
Thank you.